So these seminars support the Centre's aim to improve understanding of the complex interrelationships between society and mental health, to promote and sustain good mental health in communities, and to explore the impact of rapid social change on mental health. And in the last seminar, we talked about co-production in mental health more widely, but today we wanted to explore this topic in particular because it links really closely to the goals and research priorities of one of the programmes, in particular within the Centre, the Marginalised Communities Programme, which is led by Professor Stephanie Hatch and Dr. Hannah Kiesler. And priorities for that programme have been co-developed through a series of planning meetings with our partners. And this includes Back Thrive, Thrive London, the McPinn Foundation, as well as collaborators in research and practice, service users within and outside of the Centre. And one of the priorities that we came together to decide on was really to improve the experiences of Black communities in mental health services and ensuring that they're at the forefront of change. So before we get going, just to say that we will be live tweeting from @KCSAMH using the hashtag Society of Mental Health. And then after the event, we'll be sending a link to just a very brief feedback form that would be really very grateful if you could take the time to complete. So I will now pass on to Dr. Louisa Codjoe, who is going to introduce herself and to give an overview of today's seminar. Thanks, Louisa.
Thank you. Hello, everybody, and welcome. I'm really glad that you can join us here today to discuss and think about how can Black communities best influence mental health services. So firstly, some introductions. So my name is Louisa Codjoe. I work as a clinical psychologist in SLAM. I also work as Deputy Director for the Patient and Care Race Equality Framework, also SLAM. And I'm a PhD student focusing on inequalities research. And my research is around reducing inequalities for Black faith communities. Kate?
Hi, my name is Kate Polling. I'm a psychiatrist working at SLAM and also a PhD student working with the Health Inequalities Research Group and Stephanie Hatch, looking at mental health and particularly self-harm in our local communities.
Okay, so just a bit of housekeeping. Charlotte's already been through this, but just to try and keep your camera and microphone off unless you're speaking. If you can try and type any questions you have via the chat system, we'll try and get to it, but there are lots of people joining in. We'll try our best to answer any questions now, or if not, we'll respond to them later on. And just be mindful that there were lots of people present today, today's seminar with a wide range of views. So our aims. Today, we've come to hear evidence about inequalities and access, experience and outcomes for Black people using mental health services in the UK. I think undoubtedly everybody here wants to see services reduce these inequalities. And Kate and I have been specifically interested in how this is done. So people agree that involvement of the Black community should be central and should be, leading change and leading how we think about how to improve inequalities. We're going to hear examples around this, focusing on NHS community and partnership initiatives and community approaches shaping services independently. Specifically, we're going to think about how we can improve mental health services to meet the needs of Black communities, and also think about the strengths and challenges of community collaboration with statutory services and communities establishing independent services. So the structure for today's session. First of all, we're going to hear about mental health inequalities facing Black people in the UK. We're then going to have a panel discussion where we're going to hear from two different speakers, one around NHS and community partnerships, another around community approaches shaping services from the NHS. We're going to have some breakout discussions to discuss both of these approaches and then come back for a summary and final thoughts. So now I'm delighted to introduce Kevin Ayiro, who's going to talk to us about mental health inequalities facing Black people in the UK. Thanks, Kevin.
Right, thanks, Louisa. So my name is Kevin Ayiro, and I'm a PhD student at the Institute of Psychiatry at King's College London. And I'll be presenting today on the mental health inequalities experienced by people, Black people in the UK. Now, I should say just from the outset that I won't have any time to go into too much depth that would really do this topic justice. So instead, I'll go over some of the more recent numbers around detentions and pathways to care. And I'll also suggest some other studies that might point to other inequalities, but where further research might be needed. But of course, this won't be exhaustive. So at the moment, one of the most high profile concerns is around disparities in voluntary detentions. So that is people who have been admitted to a hospital or place of safety under a section of the Mental Health Act. Depending on the type of legislation used, these stays can last anywhere between a maximum of 24 hours and 6 months. As you can see here, Black people in England and Wales are around 4 times more likely to be detained than their white counterparts. Black people consistently make up over 10% of detentions, despite being only 3% of the population, and the rates are also higher for readmissions too. In particular, Black people are 8 times more likely to be placed under a community treatment order, which provides supervised treatment outside of hospital, but they also give services the power to recall you if they feel that that's justified. So involuntary detention is very relevant to us at the moment because of the overall number of admissions has risen across ethnicities. Of course, any increase in admissions also disproportionately affects Black people, as we've seen. And my former team at UCL and the National Collaborating Centre for Mental Health looked into this data in more detail. And we found that the yearly admission rate had risen by around 13,000 over an 8-year period. Taking all of this into account, we can reasonably assume that more Black people enter services through more coercive pathways. And research on detention does give us some insight into the inequalities experienced by Black people in mental health services. Here we can see just a snapshot of the different perspectives from a survey we did as part of the Mental Health Act review. And the top quote mentions that the person had mixed feelings. In a crisis situation, they will say that detentions can be necessary, but crises can sometimes be avoided. And they've been sectioned during 2 different episodes of illness, and both times they felt that the use of the Mental Health Act could have been avoided. So this raises not just issues around reducing coercive practices, but they also raise the need to offer Black people more person-centered alternatives to replace them and also to prevent their distress at an earlier stage. And speaking more generally about how Black people access services, a lot of the research is focused on our local communities in South London, and especially Black people who have been diagnosed with psychosis. On the one hand, large studies in South London suggest barriers to accessing services through GPs and primary care, as well as psychotherapy services. On the other hand, some studies find high rates of police involvement and lower satisfaction with the drug treatments that Black people receive. So there are both concerns over the care that Black people receive, but also the care that they aren't currently being offered. However, in a lot of cases, there simply just aren't enough empirical studies to make definitive conclusions. So often we have to suggest where further research might be needed, and I've outlined just a few of these topics below. So the first is adverse childhood experiences. This is a measure of potentially traumatic events experienced before the age of 18, and they strongly predict worse physical and mental health outcomes in numerous studies. But to my knowledge, the only study to look at racial disparities in the UK was done by Mark Bellis in 2014. And what he found was that Black and mixed race people were significantly more likely to report having more than 4 of those traumatic experiences relative to white people, and that this could potentially mean that racial inequalities in trauma experiences might be worth looking into more. We also need to look at the link between self-reported racial discrimination and mental health. One recent study asked participants whether over the past 12 months, they'd experienced one of 4 types of discrimination. The researchers then asked them whether or not they attributed this discrimination to one of their characteristics. So for example, their race. And when the authors compared people who did and didn't report racial discrimination, the people who did also reported a range of worse mental and physical health outcomes. What was especially interesting, though, was that discrimination had the worst effect on mental health in the Black people in the sample, even more so than the ethnic minorities in the sample, other ethnic minorities. But this is only one study, which only used a few measures, and we would need a lot more studies to do a real statistical breakdown of the link between racism and mental health. And then finally, Black people, so specifically Black Caribbeans and mixed Black and white Caribbean children are both 3 times more likely to be permanently excluded from school compared to white British children. And yet there have been very few quantitative studies looking at how this might affect mental health over the lifespan. So now the research that I've presented here isn't exhaustive, but to summarize, several studies suggest that Black people, Black British people experience inequalities in mental health access, experience, and outcome. The strength of the evidence is greatest for access, where we know that Black people have consistently higher rates of detention, and in many cases enter services through more coercive pathways to care. Beyond this, though, the quantitative literature is quite sparse, especially in terms of how people experience services, so patient-reported outcome measures. And research in this area would greatly benefit from high-quality data around ethnicity so that we can reduce speculation over the causes of these inequalities. And hopefully that's something that we'll go on to talk about with the patient-carer race equality framework. Okay, and thank you. And I've put acknowledgement to my co-authors on some of the projects as well.
Thank you so much, Kevin. That was a really useful rundown of where the problems are and where the inequalities are in accessing services and also in experiences and outcomes once people do get into services. I think, Louisa, you've got an eye on the chat. Were there any questions popping up that you wanted to put to Kevin? We've probably got time for a couple of questions.
No, not so far, but if any come through, I'll pass them on. Brilliant.
In that case, we might move on, but potentially invite Kevin back into to answer any questions if they do come up in the chat in the meantime. So we want to move on to the panel discussion now. We've got 2 great panelists who are both involved in different ways in how we manage to shape services to make them more equitable for the Black community, and for us to think about with them what can be done to make sure that voices of the Black community are heard and that actually results in changes to services. So I'm just going to introduce them both now, but then we're going to speak to them initially separately with some questions and then get them both involved in the discussion, because as you'll see when I introduce them, they do sort of overlap between the 2 approaches that we're interested in. So we have Zoe Reid here today, who's Director of Community Organisation at South London and Maudsley NHS Trust. And she's the SLAM representative for the Black Thrive Partnership Group as well. So as part of Zoe's role, she heads up the PCREF process for SLAM. That is the Patient and Carer Race Equality Framework, which Kevin mentioned. So that is a framework which has come out of the Independent Mental Health Act review in 2018. And the idea is to create a practical framework of organisational competencies that will enable trusts to make their services more equitable in collaboration with the community. It's going to be rolled out nationally from 2022, but SLAM is a pilot site for the next 2 years, trying to pilot this way of working and coming up with practical tools. We also have Natalie Creary here. She is Director of Black Thrive. which is a partnership between communities, statutory organisations, voluntary and the private sector, who work together to reduce inequality and injustices experienced by Black people in mental health services. So her organisation is a member of the PCREF partnership with SLAM, and they're acting as host organisation for PCREF in Lambeth and Southwark, and she herself is a member of the partnership group. So she's got experience of that process. But we're also asking her here today to talk about some of Blackfriars' other work, which is setting up a community therapeutic fund, which is setting up independent feeding spaces, independent of the NHS, to offer services to the Black community in Lambeth. So I'm just going to stop sharing a screen now so that we can see people when they're speaking. Okay, and we're going to start off with asking Zoe just to speak to us a little bit about the PCREF partnership and to tell us how this PCREF process at SLAM is going to work to ensure that people from the local Black communities are shaping services and are making services more equitable locally.
Thank you, Kate. Do you want me to?
Yes, please do. Yeah.
It's all very strange, isn't it? All this stuff done by Zoom. Great to be here. And I thought Kevin's presentation was really interesting in starting to map out issues of access, experience, and outcome, because that's the focus of our PCREF work. I mean, it's probably worth a little bit of history, which is that I think it was in 2014-15, Lambeth Council did a commission into the Black people's experience of mental health arising from the death of Sean Rigg. And Jackie Dyer was one of the co-chairs of that. And what happened from that is that they produced a recommendation, 40 recommendations, in fact, about what we needed to do to get things right for Black people locally. And one of those recommendations was that we should set up an independent advisory group to work with SLAM services. And so, if you like, for about the last 5 years, we've been seeking ways to work in partnership with local Black communities. We started in Lambeth, and then we've moved it across to the other 4 boroughs we serve, Lewisham, Southwark and Croydon as well. And I guess from that, we've become convinced in a very small way, if you like, that when you do genuinely get community members working with staff at the front line, you can start to see some improvements that make sense to the Black community. I mean, one of the big issues we think why there's a problem that the question is, why do Black people have a poorer access and experience and outcomes in mental health services that are supposed to be provided fairly and equally to everybody? And one of the things we think is the mistrust with the local community, and therefore the access routes can be more coercive rather than by choice. So we think it's really important to work collaboratively in partnership. And so we've built on our platform, and we've now got a whole governance structure with joint community leadership top to bottom. And we're now, and it's very interesting, I mean, I'll be interested to hear Natalie's contribution, because she and I were at a meeting only on Friday, thinking about how we can strengthen, with her help and expertise and her colleagues across the 4 boroughs, to get Black community completely embedded in the structures and working with us. So we're wanting to not just have a few token people on a few committees. We're trying to think, how can we really activate people to get involved in different parts of the change? So we think some people might like to work with us in identifying the problems. Some might want to work with us when we get to looking at some solutions, because one of the things that we've been doing over the last 2 or 3 years is putting together joint projects where community members and staff work together. So that's one of the things we're looking at.
I'd like to bring Natalie in a moment, but first I just want to ask one more question to you, which is when you're starting to do this work, where you've got people from outside of services, from the community, working alongside services, one challenge it strikes me is that obviously the people within the services are going to have much greater knowledge of how services work, and they're going to be in quite a powerful position because of that, in terms of making these decisions. And I wonder how you've dealt with that challenge of trying to reduce that power difference and make it possible for people to actually make changes in the services, people from outside the services.
I suppose it's It's trying to work with staff not to be defensive, and trying to provide the idea of the independent advisory groups, and hopefully with Natalie's help we'll strengthen those, is that they themselves have private conversations as a group when they can work out how they want to come in more strongly. But one of the key things, I mean, all our structures have been jointly chaired. So for example, the Lambeth group, for example, I jointly chaired the joint group with two colleagues from the local Black community. We do all the agenda planning together, we set it all up, and then we have service directors and service colleagues and community members in the room. And so that because there's always a joint chair as well, it's trying to rebalance it to some degree. But we've made some mistakes. With the best of wills, change staff have rushed away and organised things, and we've said, no, everything's got to be done in partnership together with everybody. So I think it is about, there is a knowledge differential. Having said that, I'm not a clinician, and many service users know far more about drug regimes and therapeutic interventions than I do. So it is about plain speaking and accepting, no, we got that one wrong, let's start again. What are we really talking about? And working, we did training on the joint methodology so that everyone could understand the quality improvement methodology. So there are a range of things. There'll always be the power imbalance. And that's
maybe,
yeah,
maybe we can bring Natalie in perhaps to comment on that as well from the opposite perspective, how easy it is for people to have real influence within a mental health system.
So I was just kind of touching on Zoe's kind of point about there's always going to be a power imbalance. I think that that's really important for us to always keep that in mind when we're doing this work, because I think sometimes people who work in services think just by virtue of having people from the community around the table that you've cracked it, but actually, you know, power is at play all the time. And so it's really important that we're a bit more deliberate about how we pay attention to that. And when you're yielding your power in the space, that actually people from the community can feel that they are supported enough to be able to check you to check yourself. I guess essentially that's kind of where we would like to get to. I think there is also something about when we think about, you know, people in the workforce, they're generally not trained around kind of engaging and involving communities. And I think what people often, I think, underestimate is that actually it's a real skill. So people who work in community development, like it's a craft. And so it's going to take time for people to be able to develop those skills. So from a community perspective, there is an element of patience, although we probably have been waiting too long anyway. But you know, there isn't, you know, for this kind of framework to work, essentially, it is going to require the community to continue to forgive the system for their ways. So, but I think if we can get into that practice, that is kind of great. The big question about whether Black communities can shape services, I think absolutely, and I think the work that we've been doing with the, you know, through our work through the Black Thrive Partnership, I think is a demonstration of ways of being able to place the voices of communities at the centre to influence services. So I think it absolutely can. Has it always been easy? Have we always done it well? No, but I think that through our work, we have started to gain traction, and actually from a systemic perspective. So it's not asking you about whether or not what colour you want the walls, but like fundamentally about how you're going to experience a service beyond the kind of cosmetics.
I wonder, and this is a question perhaps for both of you, if you've got specific examples of times where you've seen this work well and you've seen really effective changes happen to services through involvement. But perhaps Zoe first. I can see you were itching to come in.
I was itching to come in on another point, which is to go back, but I mean, I will answer that. I have been in situations where, notwithstanding the power imbalance, the staff have been paralysed and unable to speak with community members in the room. And that's a very complex sort of, you know, doctors and nurses know they've got the power. They can hear the service users, the carers, the community members speaking. They don't agree, but they don't have the, perhaps it's a training issue, as Natalie says, they don't have the language to how to share that. Because what we're trying to say, this joint work, that the community have got a contribution, but so have the staff. And it's how we get both those into play at the same time, and then we can go forward together. So I just wanted to say that, because I think so one of the things we're doing in our structures going forward, and that's again what we were talking about on Friday, is having 3 parallel events, what I'm friendly calling Get Fit for Partnership. So the community members to work together, the staff to work together, and the service users and carers to work together, to work out how they're all equally going to have voice and contribution and not block anybody else. And then we're going to bring everyone together, because we realize there's differential information needs. You know, words and initials can drop off the tongue of the doctor and a nurse. I haven't a clue what's going on, certainly community members don't have. So we can get ourselves up to speed to have an informed conversation. I mean, I think it's been really interesting. I mean, the work of Black Thrive, and I did say at one point, Natalie, just the words Black Thrive are having their effect in SLAM. So it's a sort of partly, you know, the fact that Jackie and others got together and got it to happen, and it's there as a living force, has an effect. And then there are some practical things, you know, I mean, Natalie can talk about some of the things going on in the Lambeth Alliance, but just going back to the little piece of work in Lambeth when we were saying we wanted to tackle the issue of why do Black people get restrained in our services, and that's a terrible experience and nobody would want that. And the idea coming out from, I think I've forgotten, I was there at the time, somebody from the community said, well, if they could just talk to a friend, you'd get it understood to you that you don't need to do that. And so we've been painstakingly trying to craft this project called, you know, Trusted Friend, where someone's in our inpatient services, they're under section, the staff know to get hold of a friend, the friend can then work with the mix, and the person doesn't need to be restrained. So there are slowly, now that had false starts, things go wrong, back to the beginning, but gradually we're starting to see that might actually have legs. And the promise that the trust has made is, if we can prove it's really having a difference, then we'll roll it out across the whole trust. I mean,
I'm just going to move across to Natalie to let her sort of speak to the same issue about whether she's seen it working and in what situations she's seen it work.
So I guess through the work of Black Thrive, like, communities have been kind of consulted a lot. So even when people are like, oh, what do Black people think? I think that we've been talking for a very, very long time, and there are reports after reports, consultation after consultation. And so I think there was an element of us just kind of needing to act on it. So I think through some of our work, we do just that. So rather than saying, what do you think? It's like, we kind of know, like you've said this 100 times already, now let's kind of just do it. And so an example of us kind of using intelligence in that way would be working with the Living Well Network Alliance around negotiating an incentivized outcome within their contract. So if Black people do better, they get paid, you know, and that is an example of a kind of structural change. Another example would be where the Living Well Network Alliance were kind of transforming a service, and they were kind of looking at the referral form and designed quite a horrible form. And we were working with them as well, kind of trying to get it to something that was kind of presentable. But actually, when we kind of shared that with kind of communities and people who'd be accessing the services, you know, they identified things that had been overlooked by us, and we are a Black team essentially. So it's really important that you continue, you know, that you don't just kind of rest solely on your own kind of social identities or your proximity to the groups that you might be working with, but actually there's still that importance to involve them.
It's interesting what you're saying about the sense that people have been asked quite a lot about what the problems are, and I suppose the question of how you get from that, from consulting people to actually it causing change within the system, is probably where the real challenge of this lies. I wonder, perhaps Natalie first and then Zoe, what particular challenges you found in trying to get things on the ground in clinical services to change on the basis of what you're hearing from engagement?
I think it's variable, and a lot of it is down to like the relationships. So there is an element of, one, you kind of need people in the system to kind of get systemic racism, and if they don't, having a willingness to be able to kind of either learn, or even if they have no interest in learning, just doing as they're told, like that's also really helpful. So if you don't know and have no interest, but you're willing to be kind of guided, that's really helpful. And sometimes things move really, really quickly. So I think when people, where their fragility around kind of racism and other forms of oppression kicks in, that's probably the biggest, blockage. And I think the other thing is a lot of it is about shifting people's mental models. Generally, people do want to make a change and do want better outcomes for Black communities. But again, sometimes by the nature of the way in which you've been trained, it's quite difficult to imagine a different way of doing things, especially when it may be in kind of conflict with what you've been taught. So I kind of like mentioned in conversations before that where we're kind of interested in testing more Afrocentric models, and we've got therapists in the system who are interested, and they reach out to talk to us about it, and then it's like, oh, that's really interesting, and then when you go, well, this is what it will involve, it's like no, so there is something about being able to embrace kind of new ideas, but it's also a recognition that they're also working within a structure and a system that can also make it difficult for them to move. So
yeah, I want to just put that back to Zoe, and I mean, loads of really interesting points coming in there. It struck me that you're saying you need the system to understand structural racism, and I think that's something that actually a lot of our trainings don't prepare us very well to understand. I wonder, Zoe, do you think the system does understand structural racism, and if not, how do we get them to understand?
No, I mean, I think that's I would preface everything we say that I've been at SLAM 20 years, and there have always been people passionate on this agenda, and there've always been doctors and nurses that have broken any rule in order to get it right for Black people. So I think what we want, though, is it to be systematic across the whole trust and absolutely predictable, that you're never going to be able to see that racial disparity again. So that, my hope for PCREF, we're taking a very structured program approach. I'm the strategic leader together with Jackie Dyer as a partnership, but we've got the head of strategy leading the overall framework, and we're quite deliberately working through the whole organization to at the highest level. So I was talking to the chair last week, and he said delivering the PCREF is a core part of the trust new strategy. We've got a new chair, new chief executive, and of course the context is different. We're in the middle of a pandemic. We've had the Black Lives Matter. That's changed everything, and I think that if ever there was a right moment to push it. So what we're saying to the organisation, and I mean, I've been on trust broadcasts and things, sort of gently saying to the chair and the chief executive, this is not going to be a small change, because when we get to communities and we get to the staff, and we're equally wanting to engage staff and communities and service users and carers, they're all three vital constituents to this. I think staff will tell us what they think about why things are going wrong. And I think they'll say, we know how things need to be structured and managed differently to enable them to give the best care. And it's going to be a challenge. It's going to be an organisational challenge, which is why we've got to drive the timetable so that we hit the board next July with these are the competencies that are missing. And this is our plan to implement them. And this is the resource requirements. And the resource, I think, is going to be as much about staff time, to work in partnership with communities, to be trained, to learn, to step forward, as it is in real money. I mean, because of Black Lives Matter, we've been running, I mean, you'll know if you're a SLAM member of staff, the time to talk about racism, hundreds of staff every fortnight in conversation, black and white, about racism, what it feels like, about white fragility, about how we're going to try and move it forward. So certainly the time I've been in the trust, there's never been such an intelligent focus and an all-consuming one where we all care and we all think getting behind this is our chance to push it over the line.
I'm noticing the time. I want to bring Louisa in now, and slightly move the conversation to talk a little bit about the Community Therapeutic Fund and this alternate way of doing things running alongside the working statutory services in terms of setting up more independent services. So I'll hand over to you, Louisa.
Thanks, Kate. Yeah, I'm really interested, Natalie, to hear some more about Black Thrive's Community Therapeutic Fund and really what motivated you to set it up.
So kind of Black Thrive is a partnership. We don't deliver services. But I think as a result of the kind of Black Lives Matter movement, kind of the COVID-19 pandemic, all we kept hearing from communities was, and also feeling it ourselves, that actually it was kind of taking a toll on us psychologically. And for us, we just felt that the system, although they need to have more kind of culturally sensitive kind of services, that actually it wasn't really moving fast enough. The underrepresentation of Black therapists within the NHS is a systemic problem. And so what we wanted to do was to, I guess, test a way of, I guess, kind of working and delivering kind of healing spaces that brought together Black therapists who may be working in the private sector or in private practice to be able to offer kind of free and affordable therapy for, Black people in the community. And what we also wanted to do was to test different models of healing. So not necessarily your kind of traditional CBT that would be offered, but kind of thinking about, walk and talk therapy, creative therapies, and more kind of Afrocentric models of healing. And again, for us to start building the evidence base around what works.
Okay, and I'm really interested to know about the sort of the models that you're focusing on. You mentioned about the sort of walk and talk therapies. Are there any other models that you're using or that the therapists will be employing?
So we piloted the emotional emancipation circles. So it's a model that was developed by the Healing Network in the States, and we found that we kind of piloted it, we'll be coming up to 2 years ago, and the group that we worked with are kind of still self-organizing and still supporting themselves, like supporting each other within their group. So there was certainly something in that, and we as a team are not intervening in that group, if you see what I mean. So we were quite intrigued to see what that would look like. So we are now planning a test, to kind of, I guess, test them in different contexts. So in the community setting and in 2 workplace settings. So one probably with a kind of government organisation, kind of civil servants, and then another one with Black therapists within a mental health trust.
Okay. And I was really interested, as you mentioned about some therapists who are, really interested, they're reaching out to you, but then when you explain the model and present it, they kind of like back off. And I just wondered how you plan to overcome that challenge, but also any other challenges that you have observed in trying to set up sort of independent ways of working.
So I think it's largely going to be through developing our own evidence base, I guess, essentially. And within Black Thrive, we are quite fortunate that we have that research capacity within our team, which a lot of Black-led initiatives don't necessarily have that to their disposal. But we're quite fortunate in that respect, and also that we've kind of got strategic relationship, with the Centre for Society and Mental Health, and other kind of universities as well. So it makes it easier for us to do that. So I think that's one element which is going to be critical for those who are like the laggards. But I think I think essentially communities will speak for themselves. So if this works, I think it's going to be a really positive thing. And I think even with all these funds that have kind of popped up, like Black Minds Matters, the Black LGBTQ fund, actually they're all oversubscribed. And so when you think about the kind of narrative about Black people not wanting to access like therapy, I think it really kind of challenges that kind of narrative.
Sure, it does absolutely. And I'm wondering what, for you, coming into contact with people who may choose a route that isn't going via NHS services, do you have a sense of what it is that the sort of benefits are, the advantages that are for them of coming via you guys?
Well, I think, it's no secret, like the exhaustion that we feel when trying to access mainstream services, and in particular when you're receiving therapy from somebody who doesn't share any of your social identities or the social identities that are most important to you. And from personal perspective, I often feel that too, where it's like, oh gosh, I'm spending the first 3 sessions of my 6 sessions just telling you what it's like to be a Black woman. And not actually being able to get into doing the work in three sessions. So I think that there is something about the comfort of having somebody who can kind of relate without having to explain everything, which I think is really important. And you're obviously not going to, unlikely to experience microaggressions and other forms of racism in that space. So I think that, those things are important. And I think the interest that we've had thus far, I think is also an indication of, Black Thrive being perceived as kind of credible and safe. And so I think that that's also kind of really important.
Okay. And I'm really interested to think also, if you think there are, what the barriers are, thinking also about your role with PCREF, and you mentioned this idea of cultural sensitivity, and how really with coronavirus and all the issues and the burdens on all communities, but on Black communities that there have been, that you feel that services haven't kind of met the bar yet. And I guess I'm wondering how you think that Black communities, organisations such as yours, can support initiatives like the PCREF, for example, NHS services to improve, and what that cultural sensitivity looks like.
So I think you can't do it without us. Like, essentially, like if somebody was saying, oh, can you design a service for older white men?
Yeah,
I wouldn't even know where to start. Like at the very least, you would, I think I'd need to go and have a conversation with at least, a few people who fit the description. So I think that, again, there is something about when you're either designing services or delivering them, that actually there is a level of humility. And I think one of my team sort of said, it's about kind of like cultural humility, in terms of actually acknowledging that you don't necessarily know everything, but also recognizing that Black people are not all the same, and so it's really important for that person who's in front of you to tell their story from their perspective, rather than you making assumptions. Oh, you're a Black person, so you must have experienced this, and you must have been beaten as a child, and all of those sorts of things. You're bringing assumptions to that, and that's the cause of your trauma. And it's like, no, actually, it's just people being racist to me, really. But so it's kind of, I think those sorts of things are important to kind of think about. I think I've lost my train of thought.
No, you're okay. Do you know something? You've got me thinking though about, you're saying that you're really interested and really keen to have Black therapists, and that idea of having somebody who can relate to you, rather than sort of spending sessions talking about. Does that mean that all the therapists who would be working in the therapeutic fund would be Black?
So for us, it's about where's the gap, isn't it? So our focus is on, Black therapists delivering therapy to Black communities, because if a Black person wants to access therapy from a white person, then there are avenues for that already. And that doesn't necessarily mean it doesn't work for you. So I have had, you know, a white male therapist who was brilliant. You know, when I walked into the door and I saw him, I was like, what's this going to be like? And he was, you know, he surpassed all my expectations. So, you know, it may work for some.
Yeah.
But for those that don't, and who are maybe reluctant to access services, then this isn't, you know, an avenue. And for us, it's also, again, like there's an element of kind of sort of healing by stealth. So actually not everything that we're going to be doing is like, come and speak to somebody. It might be about, you know, are you having trouble like with sleep? You know, and this is about how we can like improve your sleep, and kind of through those sorts of conversations, you will more than likely start to have conversations about your mental well-being. Or you know, are you having problem with debt? So let's have a conversation about debt before we kind of move forward.
I'm really interested just to see if Zoe could, if she wants to come in just to give her thoughts about the independent approach and just any comments that she has around what you've been saying, Natalie.
Thanks, Louisa. I was thinking, I completely understand and empathise with what Natalie's saying. But my aspiration goes right back to the original definition of co-production, and my original hope that every clinician would have the communication skills to communicate with every patient and co-produce the very best of mental health for that patient. And that necessarily means having the humility to understand and say, I don't know where you're coming from, let's work together and let's see what's best for you. So I can understand having a service in the community where if someone thinks, no, look, I've got enough trauma in my life, I want to talk to someone who looks like me. Now, obviously, there's diversity within people who look brown, black, you know, they all have some born here, some born abroad, etc. So it's all very, very different. But I can understand someone thinking, you know, that for me, that's just sounding, it's like I might very often choose to go to something run by women or for women. You know, it just seems simpler. So I can understand that. But of course, what I want for SLAM service is every single clinician to be able to work with every single patient to give them the best of mental health care. And so that's an almost bigger challenge about how we're going to do that, because that's what we have to get to. Because as we know, when I last looked, there were 60 different community languages being used in Southwark alone. There were, you know, through our interpreting service. So the need for that ability to, I mean, I like the frame cultural humility, to accept that the person in front of you ain't got a clue about really. You've got to have the communication skills to work that through and get the best for them. I'm
just conscious of time. So Natalie, I can see you.
Yeah, and so I agree. I mean, it would be great, but you know, if you know all therapists were able to, you know, offer a culturally kind of, you know, sensitive, you know, service. But I think also part of this for me is also about choice. And when you're from a marginalized community, actually that is one of the things that we are often not afforded. And so for me, I think that this is something about where can we use the learning from this and kind of influence, you know, the system to kind of offer better services. But I still kind of feel like that there should be space for us to also kind of be able to take the lead, you know, around our own kind of healing processes. So I think that there is room, I think there's room for both.
I agree.
Thank you very much. Thank you.
Brilliant, thank you. It's such an interesting discussion, and I think it sets us thinking really, thinking about a lot of different things for our breakout groups. And one thing we wanted to do is give the participants here a chance to have a bit more of a chance to express their own opinions and have a chat together, because we've got so much expertise in the room from not just all over the UK, but from other parts of the world as well. So what we're going to do is break you down into groups, and I'm just going to share my slide to show you what we are going to be thinking about. Okay. So what we'd like you to do within your groups is to consider one of these approaches. I mean, if you find yourself having extra time, you can sort of jump across to the other, but to give yourself time to think about it. So either of working community groups and communities working with to create independent services, or working to change the statutory services. But thinking about that, what would it look like if this approach was working from the community's point of perspective? What would a service that's working well for the Black community look like? What would it be doing? And thinking about our role in the centre, and as Natalie touched upon, this idea that actually we want to use these resources available to us locally to think about how we evaluate things and how we capture what's working. How could we do that? What would we be looking for? What would we be trying to measure, or how would we go about that kind of evaluation? What we're going to have is, we're going to have in each group, there is going to be, sorry, I'm going to stop sharing. There's going to be someone who's offered to act as scribe. They're going to be popping notes onto a Jamboard, which I've just put the link to into the chat now for everybody. That's just because we've got a lot of participants today. We've been really impressed and a bit surprised by how popular this session's been. So because we don't want it to be kind of unwieldy trying to feedback, we're going to have these discussions within groups and then be posting these messages up, posting notes on the discussions into these Jamboards so that everybody can have a look at what the other groups are looking at and thinking about and talking about. So I think I'm sorry, just noticing a question popping up, but we might bring that back into the discussion at the end when we all come back in together. I think Verity's about to pop us all into groups. Verity will be popping into different groups if anyone's having difficulties, or you can send messages in the chat to us. Hopefully that will be, everybody will be able to figure out their Jamboard. Brilliant, thank you. That's everybody back. What I would like to do, we will share the links to these Jamboards so everyone can see everything that's being put up, because there's been lots of ideas appearing there. But I'm just going to share my screen quickly so we can have a quick look through. Just to see what's being put there. I'm sorry, I'm just noticing how crowded it looks, but you can let me share it now. There we go. So you can't actually see which screen this is, but this is creating independent services. So Louisa, did you want to lead off picking a few things out here? It's such a
absolutely.
Yeah.
So absolutely loads in this. It's quite interesting watching them all come in. So thinking about accessible avenues to the most marginalised, removing cultural barriers, flexible change to working methods. So I guess different ways of delivering treatments, therapies, acknowledgement of state violence and the understanding of that in therapeutic spaces. Thinking again about choice, which came up before. Thinking about putting more funding into getting Black research and offering opportunities, representation at higher levels of training, listening to community leaders and funding these initiatives, diversity in staff groups. Your behaviour is not being represented as distress as a young BAME person. Commissioning, so I suppose what happens when commissioning comes in and commissioning needs, will that create a new power issue? And maintaining, how do you maintain sustainable funds? Yeah.
I'm just going to scroll to the next one because
yes, it's easier.
Crowded, you can see.
There we go. That's better. So for the approach to be working from the perspective of the community, for this group, not many projects in the north of England, but work included going into schools, discussing culture, religion, what it's like being from a BAME ethnicity, and workshops can lead to skills being requested and growth in attendance. Can't read what the bottom bit is. Then thinking about using mixed methods to rethink how we collect data and the importance we prescribe to these methods.
I mean, that takes on a little bit to evaluation, doesn't it? Do you want me to move on to those slides?
Yeah.
Oh, not so much here. I think it probably all went onto the first slide.
I wonder if it did. I reckon everything went onto the first slide. But just that idea of, how do you actually evaluate with an independent services? How do you capture and evaluate whether the approach is working? And I know my group certainly had a really interesting conversation about that. It's quite difficult. But thinking about regular engagement sessions with the community, and then you can sort of work on those action points. And also thinking, well, how can you how can you measure, capture, evaluate whether an approach isn't working if the change doesn't come for a number of years, if actually, you know, you don't see anything straight away? How will that actually function if you have limited sort of funding resources to keep that going?
Brilliant, thank you. If I move us on to people who were talking about how collaboration, what collaboration working looks like. So we've got again lots of comments here, and I think on the next slide, yeah, we've got we've got stuff about it being easy to refer yourself, having a common point of access, building up trust, the need for there to be resources there, things about people having choice, about it being understood how to work. So the people working there understanding things like microaggressions, taking the services to where people are, not having thresholds that are too high, so people are getting into the services if they need them, that the services are tackling social determinants as well, striking a balance between mandatory requirements for NHS services and the needs of the community. I think that sounds like an interesting discussion was happening around that, and how you reach that balance. On to the next slide. People having a voice, people having clear lines of communication with alternative support, for example, faith networks and friends. Need to address power relationships for meaningful change. That brings us back to some of the discussion we were having with the panel. So having thought about power being there when trying to build these relationships. Mention of a prevention approach, rather than just focusing on crisis, so focusing on what the community can do prior to crisis. So see less people, I assume that means that less of the people who are being seen feel that they're getting a poor service. That would show that the service was working, and that access was increased and for a prolonged period of time. So I suppose that's about people feeling that they're getting a service for long enough. And then moving on to the evaluation of this, we've got feedback from people using the service, need an end to just engaging and start shifting to action. So creating a situation where you're seeing change as well as just engaging with communities. Got community generated evidence valued, not just the academic evidence, and someone else saying less focus on evaluation, the need to be flexible and creative around how to get feedback. Experience-based feedback, and feedback from people using services. So a lot of emphasis on making sure we're actually asking the people using these services about their experiences, but also some things about having shared outcome measures, ones that both statutory and voluntary organisations can use, and collaborating to create the most pertinent outcome measures. See, there's nothing on that last page. So I think a lot here about making sure that not just the creation of the services, but the evaluation of it is collaborative too, and is taking into account what's actually important to the people using these services directly. That's a bit of a whistle-stop tour. It looks like there were a lot of great discussions in all of the groups. And as I say, we'll leave these Jamboards available for people just to go and have a bit of a closer look to, so that they can see the ideas that other groups were putting up.
I'm just interested also whether or not Natalie and Zoe have got any comments they would like to make about what came up on the Jamboards, or anything else from the groups.
It was an interesting discussion. And definitely, you can see the perspectives. It's trying to think, though. I'm still very wedded, I would be, to the PCREF approach, which is trying to change the statutory services. You know, my contention is that we will always have statutory services, even if there's lots of community offers, and I would welcome that as well. And so we really need to focus together about how we can get full community engagement in our change programme to enable all the services to have no racial disparity. So, but it was an interesting discussion, well chaired by our note taker, who was trying to multitask.
Yeah, and I think similarly, I think in our group we kind of touched on, a lot of the things have kind of already been sort of like highlighted, but the importance of kind of being kind of culturally kind of competent, but ensuring that that is also shaped by kind of communities, and also the importance of highlighting like the gaps in research in terms of what we don't know, so that there is more of an emphasis on ensuring that we kind of focus our energies on trying to kind of close some of those gaps, but also ensuring that we don't just wait on the literature, because actually people who are living it and will have insights on what's wrong and how things need to be changed.
We've had some interesting comments in the chat. Just a sort of comment around how trainee amps I teach tell me that police are very heavy-handed in Lambeth, and it's a clear racial divide between staff and service users. Do either of you have any thoughts, comments about that? I
mean, do you want to comment?
Yes, please do.
Obviously, the PCREF is about trying to identify what are the organisational competencies and the personal competencies that we're kind of missing, so that Black people are getting a poorer experience. And one of the things is about, I think, clinicians not ceding power to police when three parties are in the room. So it's all again about power differential and how they hold their ground. And I know all of us are good citizens, and when a policeman says do this, we do. But in the context when one of your patients is in distress and there's a need to involve the police, then absolutely advocating for the patient and standing there and ensuring that there's minimal intervention has to be a competence, I think. I mustn't prejudge. I know I'm being told we've got to do the engagement work, but for me that's one of the competencies we need to get much better at.
Thank you. I know that Natalie's had to leave, unfortunately. There's another couple of comments where just around this idea of the ideal situation of all therapists working with all people, all staff having cultural humility, but actually this idea that people need support right now and solutions right now, and that maybe having bilingual therapists or having therapists who look like service users may be more useful, more helpful. Kate, any thoughts?
No, I think that's a really useful insight. And I think it was in response to this discussion we were having earlier with Zoe suggesting that we really wanted to see all therapists able to deal, in an appropriate way with whatever client that they're seeing. And I think that's a really useful observation, that actually it's a difficult balance, and some people will always feel more comfortable if they've got someone who can speak to them in their own language or who's come from their own cultural background. And I think we need to recognise that. I've just seen there's another comment, I think, on the policing issue about the Metropolitan Police aiming to recruit more BAME officers, and whether that's a good strategy to reduce the conflict between the police and BAME communities. And I suppose that extends to our services more generally. I mean, how far do we think increasing representation of the communities we're serving in our services will help to deal with the difficulties and the lack of trust between services and the community? Do you have thoughts on that, Zoe? Is representation part of the answer?
Possibly. but you're still into power differential, aren't you?
Yes.
Some of that you're still a junior Bobby on the beat. The top of the structure is white. We a lot of our services are majority, a lot of our wards, a majority staff are from Black communities, and yet the Black service users feel they get a worse deal when they're on them. So then you're into how in the heck does that happen? You've got someone nursing you who looks like you, who shouldn't have to deal. You haven't got to explain about what microaggression, what racism feels like. That's their lived daily experience too. And yet still bad things happen, or, just not the perfect thing happens. So I think it's a whole lot more complex than just getting, what we're doing in the trust is trying to get 44% of the trust is from BAME backgrounds, trying to get 44% at every level, including the chief exec and the board and all the way down, to be from BAME backgrounds. And we're doing a lot of work, and it's shifting. But I'm still not hearing the parallel shifting in the experience and the numbers for service users and carers. So, you know, this needs a lot of deep thought. I do not think there are easy, quick answers. But general principle, you should be having equity in all the statutory services.
It's a really interesting point for us to finish on, and a good one for us to think on. I can see that it's nearly time, and I think Charlotte wants to just be able to wrap up and let you know about other things going on in the centre. So hand over to you, Charlotte.
Great, thank you so much, Kate, for that, and thank you to Natalie, who's obviously left, but also Zoe, Kevin and Louisa for taking the time to come and speak to us for this seminar. We're really grateful for your time, and it's been a really interesting and helpful session, and I hope people will be able to follow up and link in with us afterwards. So just to say that we will be sending around a recording of the session today coming up, and we'll also be sending around a link to an evaluation form, which it would be just so helpful if you wouldn't mind just taking 5 minutes to complete. And in the meantime, you can find out more on our website at the Centre for Society and Mental Health. Follow us on Twitter at KCSAMH, and to get in contact if you have any questions or would like to follow up. So thanks again to everyone for their time, and look forward to seeing you at the next seminar session in 2021. Have a good Christmas break, everyone.
Thank you.